শুভ্রতা আনমিউট করো।
ঠিক আছে।
হ্যাঁ হ্যাঁ,
আচ্ছা, প্রথমে কে বলবে?
আচ্ছা, আমি প্রথমে ইন্ট্রোডাকশন দিয়ে দিচ্ছি। Hello and welcome to this webinar on exploring COVID-19 pandemic and Indian perspective. We have amongst us our honorable principal sir, our eminent panel of speakers, faculty members of the organizing department, and finally the participants, faculty members, research scholars, and students from different institutions across the country. In fact, the number of registrations were so large that this seminar is always also being streamed live on YouTube. Now, this seminar is being organized by Department of Microbiology of A.P.C College in collaboration with its IQAC. Over the past few months, we have visited a number of webinars which have touched upon various how this pandemic has affected different aspects of our life, from education to economy. Now, today we'll get to hear about the nemesis itself, that is the SARS-CoV-2, from the people who probably hold the key to respite from this virus. We have amongst us Dr. Bhashwanaran Chowdhury. He'll be speaking on the ways of diagnosis and infectious control of this disease. Dr. Moha Shah, she'll be speaking on environmental impact on COVID-related diseases, while Professor Randir Chakraborty will be taking us through the molecular peculiarities and the genomic variabilities of this virus. Now, I'll request our principal sir to say a few words before we start the technical session.
Am I audible?
Yes, sir.
Yeah. So, good morning, ladies and gentlemen. We are a little bit late. In any way, now, during this COVID pandemic situation, due to COVID-19, and also after the disastrous monsoon in some parts of West Bengal, I think all you are safe and well. Now, on behalf of Acharya Chandra College, I take the opportunity to welcome all the dignitaries and participants to this national webinar on exploring the COVID-19 pandemic and Indian perspective. Just Dr. Ghoshal said that this webinar has been organized by the Department of Microbiology of Acharya Chandra College and IQAC of this college. Now, Department of Microbiology in our college was established in 90s with the introduction of honors course in this subject. Since 2004, we have been offering the postgraduate courses in microbiology in our college. We have with us today Professor Randir Chakraborty, Professor Department of Biotechnology, North Bengal University, Dr. Bhaskar Narayan Chaudhary, Consultant Microbiologist and Infection Control Officer, PLS Hospital, Kolkata, and also Advisor Microbiology and Infection Control, Fortis Hospital, Kolkata. Dr. Moha Shah, Senior Scientist, Chemical Oceanography Division, National Institute of Oceanography under CSIR. Now, they will deliver their valuable speeches in this session as resource persons. Sirs and madam, it is our immense pleasure to convey our thanks and gratitude to all of you for your kind consent to give your valuable speech in this webinar. Thanks are also due to all the faculty members of the Department of Microbiology of our college, and of course, Dr. Subhra Ghoshal, the coordinator IQAC of this college, without whose endeavor and enthusiasm, this webinar rather, would not have been possible. Now, the whole world today is under a threat of pandemic due to COVID-19. The pandemic has brought in many deaths, thousands and thousands are under quarantine, and has led a serious situation of global health emergency. The entire globe probably has not faced such a situation after 1918. Different parts of the world had witnessed infection due to several viruses over the ages with death toll, but those were confined to some specific regions. This time, the infection due to COVID-19 spread all over the world. As of June 12, 2020, about 7.73 million cases has been reported across the globe, resulting more than 4.3 lakh deaths. However, there is a silver lining that more than 3.9 million people have also recovered. In our country, the entire webinar is on perspective of India. Therefore, in our country, as of June 12, there are more than 3 lakh confirmed cases. About 9,000 people died, and more than 1.5 lakh people recovered. Initially, the infection rate in India was reported significantly lower than the worst affected countries in the globe. But the scenario being changed gradually. Every day, the result of the record of infected people superseding its previous record. Okay? There is no known vaccine and antiviral treatment till date so far. Primary treatment being symptomatic and supportive therapy. Although there is a serious attempt from different corners of the globe for the vaccine, and we hope that the vaccine would be in function very soon. Now, the need of the hour is social distancing and excellent medical care. On March 22nd, India observed a 14-hour voluntary public curfew. Further, on 24th March, the Union government ordered a nationwide lockdown for 21 days. Subsequently, there was lockdown in several phases. However, at present, unlocking has been started phase-wise. This pandemic has caused several global economic disruption, including the global recession. And the education institutions are not the exception. School, colleges, and universities are closed till date, affecting 98.5% of the world student population. This situation has caused mental stress, and in some cases, this led to depression also among the stakeholders for all segments of the society. Of course, the reasons are different for different cases. Now, in the event of unlocking of the lockdown period, peoples are gradually joining their duties, but always there is an apprehension for being infected with this killing virus. This has further posed additional mental stress. Now the problem, how to come out of this situation? Boosting of immunity in one hand, and remaining in sound mental condition on the other are the need of the hour. Respected resource persons today will deliver their speeches on different aspects on this pandemic in Indian perspective, on microbiological point of view. I came to know that about 350 participants have registered for this webinar, which includes faculty, our respected faculties from different colleges, including our college, research scholars, and the students as well. Now, it is unfortunate that due to some technical reasons, we could accommodate only 90 participants in this platform, and the rest are given the opportunity for streamlined participation through YouTube. However, overwhelming response from the participants inspired and motivated us. I am confident that the deliberation and discussions in this webinar, the participants would gather further scientific knowledge on the virus, its nature, infections, and others. And at the same time, the webinar will come with valuable suggestions and recommendations, making us better equipped to meet the challenges due to COVID-19 pandemic in Indian perspective. I wish this webinar again success. I think coming few hours will be enjoyable to you. Now, before I conclude, I would again like to offer my salute to all warriors, with doctors, nurses, health workers, and others involved for their dedications and tireless efforts for fighting this situation and keeping us safe. So, thanking you all once again. Thank you.
Thank you, sir, for very beautifully bringing out the perspective of the seminar. Now I'll request Dr. Progya Mongol, Head of the Department of Microbiology, to introduce our first speaker to our audience, Dr. Bhaskar Narayan Chaudhary. Progya.
শোনা যাচ্ছে?
হ্যাঁ, শোনা যাচ্ছে।
Good morning. Thanks to Principal Sir for his warm welcome address. We now start the lecture session. We are very glad to have Dr. Bhaskar Narayan Chaudhary amongst us as our first speaker in this webinar. Let me introduce him to you all. To start with, Dr. Chaudhary passed his higher secondary examinations in 1987 from South Point School, one of the most prominent schools of Kolkata. In that year, he occupied the most coveted position, first position in the medical stream of the West Bengal Joint Entrance examinations. He did his MBBS degree from Calcutta Medical College in 1992. He brilliantly completed his MD in microbiology from University College of Medicine, Kolkata in 1997. Dr. Chaudhary has published 19 papers in refereed journals and presented 59 papers in many conferences of national and international repute. He has been the technical assessor in microbiology and serology for medical laboratories since 2013 and the NABL lead assessor since 2019. He is also a Green OT auditor. He has been life member of various medical organizations. Currently, Dr. Chaudhary is the consultant clinical microbiologist and infection control officer, Peerless Hospitex Hospital and Research Center Limited, Kolkata, and also the advisor, microbiology and infection control, Fortis Hospital, Anandapur, Kolkata. To add another feather in his cap, he is an honorary faculty member of the microbiology department of St. Xavier's College, Kolkata. We are indeed very lucky to have him amongst us in spite of his very busy schedule. Let me invite him to deliver his presentation. Sir, please take charge.
So good morning, everybody. Thank you, Dr. Proga, for the nice introduction. Am I audible?
Yes.
Hello?
Yes.
Yes,
Yes,
yes.
yes, yes.
Okay. I think the host has disabled the participant sharing screen.
Oh, just a moment, sir.
I have to have this option.
It's done now, sir.
I can show my presentation.
Yeah, sir, it's done now. You can check.
Yes. Is it visible now?
No, sir.
Yes, yes.
Yeah, it's
It's visible.
It's visible now.
Yes.
Visible now.
Yes, it's visible.
My topic for discussion will be limited to the diagnosis and infection control because as a microbiologist, we have to diagnose infections and also guide their treatment, and also the infection control is in our hands. So my talk will be restricted to the COVID-19 diagnosis and infection control from the microbiologist perspective. So coronavirus disease in a nutshell, it initially, it was named as 2019 novel coronavirus because it's a new virus that has affected the humans. So the virus has now been named as SARS-CoV-2. SARS stands for Severe Acute Respiratory Syndrome, and CoV stands for coronavirus, and it is 2 because we had SARS-CoV-1 outbreak in 2003-4, which originated and was mainly restricted in Southeast Asia. It didn't affect India much. So this nomenclature has been given by the International Committee of Taxonomy of Viruses. So SARS-CoV-2 is a single-stranded RNA enveloped virus that likely spread to humans from a zoonotic source, possibly from bats or from pangolins. Possibly the bat origin is the most suspected now. So it belongs to the beta coronavirus family that also includes the coronaviruses HKU1, OC43, and SARS-CoV-1 and MERS, which caused Middle East Respiratory Syndrome a few years back. So that was also restricted to the Middle East, but SARS-CoV-1 and MERS had higher mortality. So the alpha coronaviruses are CoV229E and NL63. These beta coronaviruses, this HKU1, OC43, NL63, and 229E are prevalent in our country, particularly during the winter months. They are the second commonest cause of rhinitis after the rhinovirus. But these are not that virulent. Okay, this CoV2 virus spreads from person to person primarily via respiratory droplet nuclei. There is evidence of transmission by asymptomatic individuals as well. So asymptomatic individuals happen to be the most important route of transfer because these persons do not know themselves that they are infected. So unknowingly, they will transmit infection to the others. So the SARS-CoV-2, which is Severe Acute Respiratory Syndrome Coronavirus 2, is an RNA virus, identifies first in China. So SARS-CoV-2 is the name of the virus and COVID-19 is the name of the disease. COVID stands for coronavirus disease and 19 because it's originated in 2019. The mortality rate so far is projected at around 3 to 4%. It may come down in due course of time when we have more data. While the true mortality of COVID-19 will take some time to be fully understood, so far the data indicate that the crude mortality ratio, that is the number of reported deaths divided by the reported cases, is between 3 and 4%. And the infection mortality rate, the number of reported deaths divided by the number of infections, will be lower, probably, in the due course of time. WHO recommends SARS-CoV-2. Recommendations for SARS-CoV-2 are that countries should ensure adequate surveillance for SARS-CoV-2, and infection must be reported to WHO. In our country, we are reporting to ICMR, which is in turn reporting the data to WHO. So the genome of this is a novel coronavirus has been sequenced. The virus is 75 to 80% identical to the SARS-CoV-1 and even more closely related to several bat coronaviruses. Both SARS-CoV and MERS-CoV infect intrapulmonary epithelial cells more than cells of the upper airways, respiratory tract. So consequently, the transmission occurs primarily from patients with recognized illness and not from patients with mild signs. But there is an evidence that it also spreads from patients with mild symptoms and also from asymptomatic individuals who are subclinical. We are having subclinical infection. So SARS-CoV-2 uses the same cellular receptor as SARS-CoV-1, that is human angiotensin converting enzyme 2. So transmission is expected only after significant respiratory tract disease, when after significant respiratory tract disease develops. So the difference between SARS-CoV-2, MERS, and SARS-CoV-1 is that the SARS-CoV-2 was originated in 2019 December. MERS originated in 2012, and it was mainly restricted to the Middle East, and SARS-CoV-1 in 2002 in southern China. So origin, in all the cases, bat is supposed to be a common origin. And now SARS-CoV-2 has spread globally all across the country, unlike the earlier MERS and SARS-CoV-1. And this is an old slide, so the statistics is a bit old.
Sir, sorry to interrupt you. A number of the people in the audience are saying you are not audible. Could you somehow increase your microphone volume? You are not using microphone apparently.
Am I audible now?
Sir, I can hear you clearly, but some of the participants are writing on the chat box that they are not able to hear you properly.
Hello?
Hey, Navnita, তুমি শুনতে পাচ্ছ?
হ্যাঁ এখন শুনতে পাচ্ছি।
If possible,
আগেতে better কি?
একটু বেটার, হ্যাঁ।
sir, if possible, please use headphone.
I don't think that.
Okay, sir. Okay, sir. You carry on.
Hello? Hello?
নবনীতা দেখো বেটার কিনা?
Hello?
নবনীতা,
হ্যাঁ
আমি তো আগে শুনতে পাচ্ছিলাম, তোমার দেখো।
Hello?
হ্যাঁ স্যার, ঠিক আছে।
হ্যাঁ স্যার।
Am I audible now?
Yes sir.
Should I actually I gave the introduction of SARS-CoV-2 and its difference with SARS-CoV-1 and MERS. So SARS-CoV-2, unlike SARS-CoV-2, 1 and MERS, it has spread globally because the infectivity rate of SARS-CoV-1 is much higher than that of the earlier coronaviruses that were detected. In fact, it is higher than that of influenza, that is even the Spanish flu and the recent swine flu, that is H1N1 influenza. The latest pandemic virus is 2009 H1N1. So which has an infectivity rate of around 1.5. That is, one person will infect around 1.5 other persons. But this SARS-CoV-2 has an infectivity rate nearly 3, which that is one individual can affect 3 other individuals. So it has spread globally, and it has been reported from all the countries of the world. But fortunately, the mortality rate of SARS-CoV-2 is much lower than that of SARS-CoV-1 and even MERS and even influenza. That is the initial time when 2009 in H1N1 pandemic came into circulation. At that time, the mortality was very high, but now the SARS-CoV-2 mortality is projected to be between 2 and 3%, which is much less. So the clinical manifestations of this COVID-19 are mainly include the mild illness. Mainly the fever is the most common symptom. It will be present in around 95% of the cases, but afebrile cases are also common nowadays. So fatigue and cough with or without sputum production, then anorexia, that is loss of appetite, malaise, muscle pain, sore throat, dyspnea, that is respiratory distress may occur usually in due course of time, usually on day 4 or 5 of fever, then nasal congestion or headache, and body ache. Okay, so rare symptoms include diarrhea because gastrointestinal symptoms are also being reported, nausea, vomiting, anosmia, that is the loss of smell, and ageusia, that is loss of taste. Many of the patients we are saying have presented only with anosmia and ageusia, and these patients are coming mainly to the ENT consultants. And the atypical symptoms include dyspnea, that is respiratory distress, severe respiratory distress, and desaturation, which is diagnosed by desaturation, that is the saturation, oxygen saturation will drop below 95%. Then GI symptoms or fatigue. Pneumonia may develop in some of the cases, and severe pneumonia may progress to severe pneumonia and ultimately to acute respiratory distress syndrome. And then sepsis and SIRS, that is systemic inflammatory response syndrome due to cytokine storm, which occurs in around 2 to 3% of the patients who are affected with SARS-CoV-2. So the markers of this cytokine storm happen to be interleukin-6 and D-dimer, and we are also diagnosing these markers in different laboratories, including our laboratory. And lastly, the patient may go into septic shock and may die, but the mortality rate is not that high. So the modes of transmission include, the exact mode of transmission is still not very clear, but actually the indoor transmission occurs mainly through the droplets, the large droplets, and direct and indirect contact, and possibly the following fomite transmission, and not airborne transmission, but it may transmit through aerosols. So the droplets can spread up to a distance of 3 feet, that is 1 meter from the person who is infected, and the aerosols can spread up to a distance of around 6 to 8 feet. So a 2 meter, that is 6 feet distancing is very important between persons if they are without protective gear. That is, at least a mask should be worn so that the droplets do not, or aerosols do not enter our respiratory or oral tract through the unknowingly. And outdoor transmission mainly may occur through direct contact, and the most important vehicle for this direct contact is our unwashed hands. So if we touch this hand on our face, that is the eyes, the conjunctiva of the eye, or nose or mouth, unknowingly, we will be transmitting the viruses which we have acquired from surfaces to, and we will inhale or ingest those. Although ingestion is not a major route of transmission, mainly inhalation happens to be a major route of mode of transmission. So COVID-19 shading, as per the through nasopharyngeal swabs, the shading is around 65%, in conjunctival swabs around 5%, sputum sample around 77%, throat swabs around 44%. It is shed in stool, but the virus is not infective through stool. And urine is not much affected, and blood, the statistics vary. Some say it is as low as 1%, and some say it may be around 20 to 40%. And sample collection is very important. The most important sample that we advocate to collect is a nasopharyngeal swab, because that has the highest yield amongst the samples that can be collected easily. It has more yield than oropharyngeal swab. So nasopharyngeal swab will have an yield of around 65%, and oropharyngeal swab around 30 to 35%. So what we are doing, we are collecting both the swabs, nasopharyngeal swab as well as a throat swab from the same individual, and putting them in the same viral transport media, so that the detection rate increases to more than 90% from a single sample. Yet there may be some false negative cases if the sample is taken in early in the infection phase, mainly within 72 hours of contact with a positive case. So the virus enters our body and it takes some time, around 72 hours to 48 hours to around 14 days. That is the maximum incubation period. So the mean incubation period happens to be between 5 and 6 days when the symptoms manifest. Usually the patients will come for diagnosis only at that time. But nowadays, since we are also having testing the asymptomatic individuals, asymptomatic contacts, and also it is done for pre-operative cases, the patients who are posted for surgery, we are doing it routinely in most of the laboratories, in most of the hospitals. So we are detecting that in many of the asymptomatic individuals, in several of the asymptomatic individuals, the virus is being detected. So the other samples are sputum and lower respiratory samples, but they will be available only when the patient develops pneumonia, that is viral pneumonia. Okay. So the strategy for COVID-19 testing in India, as per the ICMR latest guidelines, we are following these guidelines of 18th May. That was the last guideline from ICMR. So all symptomatic, that is ILI means influenza-like illness, individuals with history of international travel in the first 14 days. So it is now a non-entity because there has been no international flights for the last 2 months or more. Then all symptomatic contacts of lab confirmed cases, all symptomatic healthcare workers or frontline workers involved in containment and mitigation of COVID-19, all patients of severe acute respiratory infection, that is SARI, asymptomatic direct and high risk contacts of a confirmed case to be tested once between day 5 and day 10 of coming into contact with the confirmed case, all symptomatic ILI within hotspots and containment zones, all hospitalized patients who develop ILI symptoms, all symptomatic ILI among returnees and migrants within 7 days of illness, and no emergency procedure should be delayed for lack of test. However, sample can be sent for testing is indicated as above. And also there is an others category where we are including these pre-operative cases and the health checkup cases. Many persons are approaching us to check whether they had been infected with SARS-CoV-2 or not. So the tests that are available for SARS-CoV-2 includes the most important is the RT-PCR, that is real-time reverse transcriptase-based PCR, which converts RNA into DNA, cDNA, and then amplifies it. So we have this test in the form of open system, that is the real-time RT-PCR, where we have to perform the RNA extraction first and then the amplification. And also the closed systems, that is the CBNet cartridge-based nucleic acid amplification test, where we have just to introduce the sample into the cartridge, and then all the steps of PCR amplification occurs there. And these are fast methods also. In case of Gene Expert, the time taken for a positive report is only 35 minutes, and for a negative report is 45 minutes. We have the TrueNat system, the MolBio system, the BioFair system also. But in many of the labs, we are doing the RT-PCR, open RT-PCR, including our lab, because we can do many tests together, at least 70 or 90 tests together in RT-PCR. But in case of the CBNat, we have to do, we cannot do 4 tests simultaneously, more than 4 tests simultaneously. So this includes the screening gene. So the best PCR kits will have a screening gene, that is the envelope gene or E gene, which is a marker of beta coronavirus. So we have to have that in the panel. And some of the confirmatory genes, at least 2 confirmatory genes are preferable. At least if one of them is positive, we can declare the case as positive. But E gene should be positive in most of the cases. So this includes the S gene or RDRP gene, which belongs to the same category, and the N gene or nucleotide gene. So the N2 is the most specific for SARS-CoV-2. And RDRP stands for reverse, RNA-dependent RNA polymerase. And another test category is the antibody detection. Now only the IgG antibody detection has been approved by ICMR, but ICMR is advocating for this antibody-based test to be used only for epidemiological surveillance and not for diagnostic purpose. They have done it in many centers across the countries, particularly in the government setup, and they have detected that many of the individuals are having this IgG antibody, which is the specific IgG antibody against the spike protein, which is a very specific protein characteristic of this virus. So this IgG antibody specific for SARS-CoV-2, if it is found in a person, it is an indication that that person has been infected by SARS-CoV-2 in the past and is now having protective antibody in his or her body. So that is only for epidemiological surveillance purpose till now. So other lab investigations include the complete blood count. There will be leukocytosis with increased neutrophil count and decreased lymphocyte count, mainly due to the immunological response to the virus, and decreased platelet count may occur if there is disseminated coagulopathy. Then albumin is usually decreased due to impairment of liver function. Lactate dehydrogenase is increased. Alanine and aminotransferase is increased. Then AST is also increased. Total bilirubin, this may be increased due to liver injury. This occurs in due course of time. And creatinine, cardiac troponin, D-dimer may get increased due to active blood coagulation or disseminated coagulopathy or DIC. Then the marker of cytokine storm happens to be IL-6, and ferritin is also increased due to severe inflammation. And another important marker happens to be C-reactive protein, which gets increased due to severe viral infection. And it is also a marker of cytokine storm. If IL-6 is not available in the laboratory, you can also do serial CRP to detect the prognosis and progress of the disease. And procalcitonin may increase if there is secondary bacterial infection. So the virus mainly attaches to hemoglobin and decreases the oxygen saturation in that way. It doesn't decrease oxygen saturation by binding to the respiratory epithelium. So immediate implementation of appropriate infection control practices happen to be very important in tackling this virus, and it should be initiated at the point of entry of the patient to the hospital. And the most important strategy is ensure hand hygiene and use of PPE, that is personal protective equipment, when indirect and direct contact with patient's blood, body fluids and secretions and non-intact skin happens, and also contact with the patients. Keep at least 1 meter distance between suspected patients and yourself. And you have to ensure the safe waste management also, that is as per the National Biomedical Waste Management Guidelines of 2016 and 2018. And there are certain specific guidelines for SARS-CoV-2 also, which have been issued by the National Pollution Control Board, and all the hospitals are following this. So possible routes of exposure of these infectious agents in the lab may be through contact as well as through the aerosol generating processes. So all the aerosol generating processes like handling the fluids and transferring them should happen within a biosafety cabinet, which is at least class 2A2. That is a BSL2 cabinet, and the lab should have that facility if they are conducting this testing for SARS-CoV-2. Our Peerless Hospital is a testing facility. We are doing both by RT-PCR as well as by CBNAT, that is Gene Expert. And so we are having all these protective PPE for the technicians when we are doing this testing. So infection prevention depends on 3 factors, that is limiting human-to-human transmission, reducing secondary infections, and preventing transmission. That is real-time reverse transcriptase-based PCR, so which converts the most RNA important, as I already told you, is a hand hygiene. That is, with hand hygiene means hand washing with soap and liquid soap. Usually we are advocating, and water or alcohol-based solutions that results in hand disinfection. And use of PPE, respiratory hygiene, that is cough etiquette or sneezing etiquette, that is very important, and other practices. So contact precautions, droplet precautions, and airborne precautions are very important. And the most important is that you have to have hand hygiene, and a surgical mask is enough. A triple layer surgical mask is enough if you are working in a lab where the chance of infection is low. So we are triaging the categories into low risk category, moderate risk category, and high risk category. So low risk category is say the workers were not in direct contact with the patients or with their samples. So there they will have hand hygiene. They have to wear surgical mask, and they have to wear some eye protection. If they are not having specs, they have to wear the goggles. Okay. or special goggles or eye protectors that is available, or eye shield or face shield. This is the minimum requirement. The gown is not the minimum, not required in those cases. But in case of moderate risk areas, they have to wear an additional gown and preferably an N95 mask. But since there is dearth of N95 mask, we are advocating to wear a surgical mask on top of the N95 mask so that the N95 mask can be reused. And we are telling to not to reuse an N95 mask for more than 96 hours at a stretch. Okay, so N95 mask covered with a surgical mask, gown, and gown, preferably a plastic gown or even a surgical gown with a Macintosh or plastic overall on top of it, and gloves, and the eye protection, that is either goggles or face shield, should be worn in moderate risk cases. And in high risk cases, the patient should, where there are aerosol generating process, the patient is collecting, the healthcare worker is collecting samples, that is sputum sample. There will be sputum or throat swab or nasopharyngeal swab. There will be gag reflex, and there will be production of droplets from the patient. So here the patient, the healthcare worker should be in full PPE, and also while performing, opening the samples in the biosafety cabinet and doing the RNA extraction, they or loading the sample into the cartridges, they should be having a full PPE. Or even the technicians who are working with respiratory samples of patients for other purposes, say culture, or opening the fluid samples for doing some maneuvers, technical maneuvers, they have to be in full PPE. Full PPE may also imply, doesn't only imply the that is a plastic gown, full overall. They may also wear the surgical gown with a surgical, that is a plastic overall on Macintosh on top of it. But they have to wear double gloves and an N95 mask with a surgical mask on top of it, and goggles covered with a face shield or eye shield. Okay, so that is the full PPE. And you have to, hello, 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 am I audible?
Yes, yes, sir.
Yes, sir. Yes, sir.
So these are the 5 moments of hand washing: before touching a patient, before clean or aseptic procedure, then after body fluid exposure or risk after touching a patient, and after touching the patient's surroundings. This also includes the patient may be replaced with a sample also. So after touching the surroundings of the sample where we are handling the sample, the maintenance of the biosafety cabinet, the cleaning of the biosafety cabinet with UV lamp, then 70% alcohol, and putting on the airflow is very important. So I'm not going into the details of intricacies of hand washing, but you know, we have 2 processes. One is wearing the PPE, that is known as donning, and while doffing of the PPE. So the doffing is more important than donning. During donning, you have to do one test, that is the when you are fitting the mask on your face, even a surgical mask or an N95 mask, you have to see that there is no leakage from the mask. If your goggles or eye protectors become moist or there is fogging of that, invariably you should know that there is some leakage from the top of the mask. So you have to fit the mask properly over your nose so there is no leakage. And we have to inhale deeply, and the mask should cling to your face, and then exhale. First, we have to exhale strongly so that you see that there is no leakage. This applies particularly for the N95 mask. Then inhale deeply so that you see that the mask is clinging to your face, so there is no leakage. So this is very important, and you have to wear double gloves. Hello, this is how you put on your mask. I'm not going into the details, but very important is a doffing. During the doffing, you should be sure that you are not touching anything in front of your with your bare hands. If you unknowingly touch the front surface of your body, then you have to discard the first pair of gloves. Actually, you have to do hand hygiene after each and every step of doffing. So the removal of doffing is very important. I'm not going into the details, but everything you have to remove from behind your body. Okay, not touching the front, and doing hand hygiene after each and every step. And this packaging of specimen and transport of samples is another important thing. You have to have the sample transported in triple layer packaging and maintaining cold chain. That is, the sample should be transported either in dry ice or with ice packs, and the temperature should be maintained between 2 and 8 degrees Celsius. And these are the biosafety guidelines. All procedures must be performed on the proper risk assessment. Then before inactivation of all specimens should take place in validated biological safety cabinet. Non-propagative laboratory work like sequencing NAT should be conducted at facilities and procedures equivalent to BSL-2. Propagative work, that is virus culture, isolation, or neutralization assays should be done in laboratory only with BSL-3 facilities. And appropriate disinfectants with proven activity against enveloped viruses, that is hypochlorite, bleach, or 20% alcohol, or hydrogen peroxide, which is very good against these viruses, or quaternary ammonium compounds should be used for disinfection. Aerosol formation should be done, as I have already told you, with caution. Laboratory practices and procedures that are basic to good microbiological practices should be followed. Personal wear dedicated to the laboratory clothing, that is scrub suit, should not be worn outside the laboratory or changing room. And validated or certified primary containment devices should be used. Routine diagnostic testing of patient specimens can be handled in a BSL-2 laboratory using standard precautions and using automated instruments, and the work area should be cleaned with disinfectants. The best disinfectant may happen, or we may use a bleaching solution, 1000 ppm or 0.1 per general surface disinfection, and 1% for disinfection of blood spills, propyl alcohol, and 0.5% hydrogen peroxide or quaternary. These are the best disinfectants. And waste management should be done as per the National Biomedical Waste Management Guideline to ELO. That is, we are discarding those things into ELO. Which are the non-plastic material should go into ELO because they will be ultimately incinerated. So we are putting into double yellow bags and then tying the bags very well and very securely, and then writing COVID-19 on top of that. And we have to, they are all barcode marked nowadays. So, and everything that is made of plastic should go, that is gloves, etc., should go into red. That is double red. Autoclave these samples in a waste autoclave before handling them over to the biomedical waste agency. We are outsourcing this mostly to the outsourced agencies. And white and blue is mainly for glass and white for the shops. So that is the waste management that we are following. I think that is the last slide from me. So these are the references. So if you have any questions, you can ask me. Thank you.